Welcome to day 2 of our partnership conference. Wait a few minutes while the dim wears down. I just wanted to start this morning by telling a joke. Just kidding. I just wanted to get your attention. I have a song I could sing in French. All right, thank you. Welcome to day 2, everyone. J'espère que tout le monde a aimé les présentations.
I hope you enjoyed our presentations last night that generated good conversation.
Reception yesterday and over dinner last night. It feels as though there's a lot of energy in the room. I don't know if it's just we're back together after so long of being away and not being in person, but I think there's been a great excitement, and I think we're encouraged by and proud of the work that we've done so far, and certainly recognize that there's a lot more work that's left to do. I think we're encouraged by the level of commitment and collaboration that we've all been experiencing over the last few years, and really committed to making a difference and to keep going. And I was recalling the words that Dr. Alika Lafontaine told us yesterday around, when you're feeling desperate or a little bit disheartened by the slow progress. It's just to remember that we are making a difference, and I think that's good food for thought. So thanks for that. I have a few housekeeping notes before we start. There was on the screens this morning, and I think on your tables again, just a reminder, share the warmth. Partageons l'espoir, l'organisation qu'on va soutenir.
Share the Wealth is the nonprofit we are supporting.
Make a donation, that would be wonderful. It's a great way to give back to the community that's hosting us at our conference. Twitter, for those of you on Twitter, and I can't tweet and do this at the same time, but I was looking at the tweets last night, so thank you for all of you who are tweeting. Just a reminder, hashtag Think Digital Health, hashtag Santé Numérique en français.
Digital Health hashtag for Twitter.
You did receive on each of the tables, there's an infographic there. And this is something that we've just put together, and we're hoping that's a sort of a great summary of the work that we're doing at InfoWay, and in collaboration with our jurisdictional partners and with CIHI. And so it's really around connecting health and what it is that we're trying to accomplish in one easy to read, succinct infographic. So that's where we are now. And so when I talked earlier about making a difference, and we all, and so much so yesterday, we heard very much around trying to improve the experience for our patients and our families and caregivers. So I think it's quite appropriate that we start the conference again today with a patient partner. So I'm happy to introduce Anne O'Riordan, as she's one of our patient partners, and full bio in the app. But Anne has been very involved with InfoWay and a number of other organizations. So thank you, Anne, for the work that you do, and welcome.
Good morning, everyone. I am a patient living with sarcoidosis and chronic pulmonary embolisms. I am also, like 1 in 4 Canadians, an informal caregiver for loved ones. And I can tell you that the stress I have experienced in that role has been much more challenging to live with. I can't opt out of being a patient, nor would I neglect my responsibility as a caregiver. So I enthusiastically embrace my role as a patient partner, as a way of maintaining hope and personal agency as I contribute to an improved healthcare system. And I'm excited about what lies ahead. I believe we are at an inflection point in healthcare, perhaps even a watershed moment. With accelerated change and adoption of digital health, this is the ideal time to recognize and fully embrace these crucial innovations with the goal of equitable access to quality healthcare. Interoperability, access to information, sharing of data, what I now recognize as shared care, which is much easier to say. These are touchstones for the work of Canada Health InfoWay and many of us here today. And I'm proud to be a patient partner with you at this important time of change and opportunity. When we join you at the table, we offer authentic stories and real-life applications for your ideas and initiatives. We might confirm or challenge the relevancy of a new project. We may offer novel approaches to pilot your ideas, or raise issues that affect us and affirm your work as a priority. And as our patient partner communities evolve and flourish with principles of equity, diversity, and inclusion, we begin to reflect our national population's unique blend of healthcare needs, experiences, and expectations. Much of our passion arises from lived experience. We want to improve that experience for patients and those who provide our care. As patient partners, we keep your work real. Thinking about my own experience as a patient and what I hear most often from other patients and caregivers, I'm focused on two priorities, which I urge you to consider moving forward. The first is access to my own health record, which Minister Duclos reminded us is a right we are all entitled to, but which is not yet a reality. Like many Canadians, I don't have it. I don't have access to my own health record. I know you are working on solutions that will benefit all of us, regardless of where we live, work, or travel. And please ensure that I will also have the ability to contribute to that information in order to be a fully informed and active member of my own healthcare team. Throughout the pandemic, I have been tracking my mental health through the online program Together Wellness Canada. I would love to document and share that data with my primary care provider through my electronic health record. And I rely on you to make this a reality. The sooner, the better. And I'd like to commend the work of TELUS Health. They told us about the wonderful accomplishments they've made in Saskatchewan, Alberta, and BC in particular in making this a reality. And I hope that Ontario soon will catch up. My second priority is that compassion continues to be at the center of healthcare. With the rapid expansion of digital health, people are worried about losing the personal touch in healthcare, which holds the potential for those moments of connection that Dr. LaFontaine highlighted as a source of his resilience. He knows he has made a difference in a person's life when that happens. Humanity in healthcare relationships must be protected. In fact, I want to share a few examples of how digital health does enable that compassion to remain. At a recent conference hosted by Plane Tree International, I was proud to hear Dr. Roy Sigelstein, Vice Dean of Education at Johns Hopkins School of Medicine, quote our renowned Canadian physician, Sir William Osler, as he explained the term personomics. He said, "It is much more important to know what sort of patient has a disease than what sort of disease a patient has." This kind of humanity can be successfully incorporated into the electronic health record. Elizabeth Tracy, a chaplain at Johns Hopkins, learned about the lack of human connection in the ICU during the height of the pandemic, when most patients were intubated and often lying prone, preventing almost any form of communication between a patient and their team. Elizabeth contacted family members to learn about their loved ones, and she made 2-minute audio recordings called This Is My Story, or TIMS, clearly a different connotation in the States than in Canada. And these were shared with the team and incorporated into the patient's electronic health record. As the team did their daily rounds, they could listen and learn about their patient underneath the tubes and machines without taking any time away from their demanding schedules. Elizabeth told me the effect was dramatic. I have seen the files humanize not only the patient, but the entire medical team, giving them a moment to resonate with their own humanity. Similar initiatives are being tried here at home. The recent publication entitled This Is Me, Promoting Person-Centered Care Within the Digital Health Environment, describes a patient landing page that is included in the electronic medical record for inpatients at the Centre for Addiction and Mental Health in Toronto. It includes a person's strengths, values, goals, fears, family makeup, and perhaps the importance of their family dog. So as you continue to create and implement the newest and best digital health solutions, I challenge you to include strategies that guarantee access to information and compassion, because patients and healthcare providers rely on you and will benefit from your efforts. Thank you.
Thank you so much, Anne. I think access to information and compassion are great messages to deliver to us, and so we've heard it from our patients, folks. And I love that Tim's story. And if you could have a double-double of Tim's in Canada, that would be awesome. Next up, Cassie Fraser. Cassie is not only a senior director with us at Canada Health InfoBuddy, but she is the president of the board of directors of Digital Health Canada. And this is Digital Health Week. I think you all know that. And we're so thrilled that there's so many different organizations that are celebrating events and hosting initiatives and making big announcements during this special Digital Health Week. And so Cassie has a special announcement to make. So over to you, Cassie.
Well, thank you, Sheila. And I'm really happy to be here today on behalf of Digital Health Canada to be announcing the 2022 Women Leaders in Digital Health Awards during this Digital Health Week. And for those who may not have heard Sheila's proper introduction yesterday, she's an inaugural winner of this award. So I stand here in very esteemed company. Fluff your hair. And I know there's many of you out here as well who are also award recipients. So since 2017, the Women Leaders in Digital Health Awards annually celebrates the top 10 visionaries harnessing the power of IT to transform health and healthcare in Canada. And so without further ado, here are this year's award recipients. In the Emerging Professionals category, Dr. Charlene Ronquillo from the University of British Columbia. In the Leaders category, Samina Abidi from Dalhousie University, Vanessa Kinch from Northern Health Authority, and Dr. Dina Kulik from Kid Crew. And finally, in the Executives category, Beatrice Edelstein from Humber River Hospital, Duska Kennedy from North York General Hospital, Dr. Zaina Kayat from Teladoc Health, Quinn Pham from the Center for Digital Therapeutics, Tanya Tajarian for the Center for Addictions and Mental Health, and Angela Tabando from Ontario Health. So if you will, please join me in one more round of applause as we celebrate and congratulate these outstanding women leaders in digital health.
Thank you, Cassie, and congratulations to all of the winners. Okay, our opening keynote presentation, he's not a doctor, Mr. Steve Posnack is the, I'm going to read your title, Steve, but I want to get it right, Deputy National Coordinator for Health Information Technology at the ONC, the Office for the National Coordinator in the U.S. And as many people in the room know, they're doing a lot. The full bio is available on the app, so please consult the mobile app for the full bio. I won't go through it all. But Steve is also the chair of the Global Digital Health Partnership. The U.S. is the secretariat this year, so he's doing a lot of really important things. And we really look forward to hearing about what you're doing, Steve. So welcome. Thank you.
All right. Is the lapel on? We're good? Okay. Usually I talk to a room that's this way as we were discussing at dinner, so now I have to make sure I give love to the left and the right and look both ways. Pleasure to be with you. Thank you very much. I'll say bonjour, if I got that right. I grew up speaking Spanish, so my brain always wants to switch into Spanish anytime I have an opportunity to do a foreign language. Okay, so I had to submit my slides in advance, and I had to come up with a title, and so I came up with the digital health in the U.S. because I wanted to give you roughly a sense of the past 15 years or so of United States health policy, digital health change, and what you can expect from us going forward into the future. One programming note, the clock isn't ticking, so if you want to do that, or the table can help me in terms of like 15-minute warning maybe. So I called this policy, progress, and perseverance. And the primary reason why I did this is to use it to extol the virtues of the Oxford comma. And so for those of you that are Team Oxford, you're with me. All right, very good. Anyway, thank you, yes. All right. Brief story about me, as the bio and everything can describe, but to give you a quick sense, I grew up in New York, Long Island, if you're familiar or have family. Went to school in Worcester, Massachusetts, which isn't too far away from here. Happened to come up to Montreal in my younger days. And then went to Maryland for my graduate work, got a job in the government, and on a daily basis I give presentations to two-dimensional figures without legs. Now, it's great that I'm here in 3D and people with legs. So very excited, awesome opportunity, and I want to thank my great partners from InfoWay for the invitation. Went the wrong way. There we go. Okay, so very quickly about our office. We're part of the United States Department of Health and Human Services. We were originally created under an executive order. So for those of you that are familiar a little bit with United States policy, that means if a president comes in, they can rescind an executive order because it's at their direction. So it's really important for us, as of 2009, when the HITECH Act was passed, to be codified in law. So now it's a little bit harder to get rid of us. We have formal, authorities and a budget that's attributed to our office. And we progressed ever since from there. And the HITECH Act is really important because for those of you that are familiar with US health policy, that was when the quote-unquote meaningful use program, the large EHR adoption program, was first set in motion. And I'll talk to you a little bit about what that looks like now that we can do the retrospective and compare and contrast to what the future is. We received, about 8 years later, another law that helps shape who we are as an executive branch agency. Just like your experience, I'm sure, with other government agencies, we get new instruction and new responsibilities from our legislative branch. And so the 21st Century Cures Act, which was passed right at the end of 2016, gave us a whole new set of authorities that I'll talk to you a little bit about how we're implementing as well. Okay, so really briefly, in terms of the US digital health landscape, and I'm not going to read through the whole listing of bullets here, but I wanted to give you a sense of, we operate at a very large scale, over 300 million individuals. The federal government, unlike some of our European colleagues or other nations around the globe, we don't run as much digital health national infrastructure as may be expected. A lot of it comes down at the state level. It's a collaboration between public and private partners. There are certain areas where we step in or play a role, but that again is dictated by congressional action and where they choose to have the Department of Health and Human Services provide specific national type infrastructure and services. So lots of layers of governance. At scale, we have close to 5,000 hospitals, many hundreds of thousands of ambulatory doctors and clinical professionals in the space. Our hospital market is pretty diverse. Certainly though, a power law of sorts where the top 5 in the hospital segment really occupy about 80% of hospital electronic health record software developers. The ambulatory space is a lot more diverse, although we have the same type in the 10 to 15 top developers. They support roughly 70-75% of the ambulatory providers. But you have a really long tail in the software market where specialties and other micro markets exist in terms of support for healthcare providers. And then lastly, from a network infrastructure perspective, many US states, as you'll see from one of the graphics that I have health information networks that operate in their state or across state lines in different regional jurisdictions. We have other national networks that have sought to consolidate and scale further the network connectivity that exists across the US. And all of that goes to the point of we're a diverse population. We travel to different states. We get jobs in different places. We go to university at different times when our parents kick us out of the house. And we have different opportunities to travel about the country and get health care in various different ways. And so the private sector plays a significant role in our healthcare delivery system as well. So I thought I'd give you a sense of what we do. Often federal agencies are a little bit like a black box. You see someone like me, I pop out, maybe like the groundhog, and I'll say, hey, this is what we do. And then we go back in and we do our thing. So when you think about our office, we really focus on 4 specific key activities. We do a lot of work on standards development and engagement with industry around advancing standards, and that includes financial investments to standards development organizations. And so we have a grant with HL7 as one example, where in order to help facilitate and further our standards interests domestically, we work with the standards development communities to help finance some of those activities. As many of you know, and hopefully some of you participate, they're volunteer driven. And so everyone else has a day job that's going there, and they need additional support. And so we try to do that from a government digital health agency perspective. Certification is one of the unique responsibilities that my office was charged to do by Congress. And so as you're familiar now with the Meaningful Use Program, which was for adoption, we run a certification program that has a regulatory overlay to it as well. And so we go through cycles of regulation every 2 to 3, 4 years to adopt new certification requirements, new capabilities that are expected of electronic health record software in the United States and for that market. And then lastly, we focus on health information exchange, and that includes provider-to-provider type exchange, provider-to-patients, this was just mentioned by the eloquent remarks. Giving patients access to their data is a high priority for our government as well. It is a right as well under our national law, and I'll give you a little bit of a sense of how that's going in a bit. And then lastly, one of our superpowers as a government agency is that we work consultatively with all of our other peers, specifically across the US Department of Health and Human Services, which is a pretty expansive agency in our executive branch that covers a wide range. So that includes our FDA, our CDC, our NIH, so any of the big acronyms that you may be familiar with, they're all part of our overall umbrella. Now, while they may behave like they're not part of the overall umbrella, they're all part of one HHS, as I like to describe us. And they don't always have the digital health expertise that's necessary to advance their mission to 21st century care. And that's really where my team steps in to help provide them with those internal consultative services as well. So that's a lot of the coordination that we do from a federal perspective. So that's kind of the overall hand wavy. That's really not the most important stuff. It's really how we do it that I hope will resonate for you as well. Few regulatory responsibilities, I covered some of that. The second one that's there in quotes, information blocking, came out of the 21st Century Cures Act. That's a phrase that Congress chose to use to describe not sharing electronic health information when it should be shared. And our law now has, to date, requirements that have an expectation that health information will be shared unless there's a particular reason not to. And we've established certain exceptions for those cases. The federal agency coordination already covered. To the right here, we operate in a few different areas of interest. Certainly the technical that I already covered. Workforce is often underrepresented or described in terms of the work that we do, recognizing that we're operating now in a market segment, in an environment where we need highly trained professionals. Had some the breakfast meeting earlier with CIOs and other data analytic type folks. They are few and far between in terms of getting that type of expertise into the markets that we need. And as we look to use the digital data that now exists across our healthcare system, having trained professionals and working with universities and working with other types of training programs to bring in a new workforce, especially as we experienced throughout the pandemic, high data need experience, low expertise on the analysis side. And so, a lot of those experiences that we had in terms of pandemic analyses and helping to shape and drive policy were somewhat limited by the fact that there were only a certain amount of people that could really do the work and understand how to process both the outputs of the data and analysis and then explain it to policy officials as well. Other work that we do is around policy standards work, which is kind of the policy tech aspect of things. Policy to establish trust among different parties. As much as we all want to have that human aspect of healthcare, there's still business relationships, there's still competitive markets that exist, especially in the United States, and that financial dynamic in terms of fee-for-service versus value-based care all affect how interoperability gets put into place and different systems that are used. And so a lot of the work that we do is around public-private collaboration, holding workshops, events like this. We will be having, about a year from now, an annual meeting. So if any of you want to come south of the border, I'll make sure I pass along the information. All would be welcome to attend. And then we also engage in, like was mentioned, global digital collaboration and investments through other types of work that we're involved in. So how is it going? This is the drum roll please question. Electronic health records adoption. The program worked. And as you saw from the animation here, I have on good authority that you understand what a hockey stick is. And I was told by the statisticians that this is what a hockey stick curve looks like. But I labeled here, 2009 is when the HITECH Act was first passed. Meaningful use stage 1 kicked in right about 2011. And then you see rapid adoption based on the ability of our surveys. All the way, hospitals now, rarely would you find a hospital that isn't entirely electronic at this stage. And then, the ambulatory market is, again, as I mentioned, pretty diverse. We're dealing with generational and cultural adoption, type aspects, which are different than the hospital markets as well. So I think we'll start to see that creep up, over time, but it's going to be in this plateaued state for quite a while. But that being said, it's kind of following an 80-20 rule where, as we get into that 20%, it's going to be specialties and other areas where electronic health record penetration is a little bit more complicated. So that just gives you a sense of there's a lot of digital data now over the past 10 years that exists in our healthcare system, and we want access to it as individuals. I forgot the lapel mic was there. Native New Yorker, I talk with my hands. So, we want access to it. We want our trading partners to have access to it. We want it to be used for better coordinated care. There are challenges, though. And so I pulled on the left side here just some recent headlines of journal articles and perspectives. With any new technology, with any deployment of something this complicated at scale that deals with lots of partners and lots of interpersonal relations, the challenges of healthcare diagnoses, there are issues, and we need to work through them. But these are better problems to have, looking with the glass half full, than not having electronic health records at all. And so as we've made progress, we've identified new challenges and new issues that we need to overcome. And part of that is with technology, part of that is with systemic change in healthcare overall. And so we've seen on the right side, we have generated some positive momentum. If you ask healthcare providers today, would you ever go back to paper? They don't answer that question. They would never go back to paper. They won't go back. But they have a lot of feedback for you. The usability, the interoperability, different use cases, and patient populations that they want to be able to monitor and manage. Where's the AI? Where's the automation? A bunch of other things that they want now, which they didn't even know they wanted before when they were on paper. And so there's a lot of opportunity for us going forward into the future, and keep in mind. And the last one I'd highlight there in the bottom right corner, the acronym there is PDMP, is Prescription Drug Monitoring Programs. So that has to do with opioids. So we have opioid registries in each of the states in the U.S. For prescription drug monitoring, and that's really first started out as a law enforcement issue because they wanted to find opioid abuse and the like. It changed, though, over the past, I would say, 6-7 years to a public health issue. And so we have this interesting dichotomy between law enforcement related purposes and public health related purposes, where as we start to see opioid addiction, which is still an epidemic in the US and still something our administration is really focused on, providing tools to healthcare providers to get information from these registries at the point of care when it's going to make the most impact as part of a clinical intervention for someone that may have a substance abuse disorder. And so those are things that we can enable now with additional connectivity, with electronic health records. Things you couldn't ever do on paper, you can now see the possibility of from a digital perspective. Individuals' engagement. Couldn't have set up the earlier remarks any better. So we have a survey that we do with one of our other federal partners. Obviously with surveys, the data is a bit old by the time we get it in and analyze it and put together nifty charts. So I'll be really curious to see what 2021, 2022, and 2023 look like in terms of the pandemic effect. Because what we've seen is that there's this relationship, and you can't undervalue the relationship between and the influence that a healthcare provider, in this case, as I've learned the Canadian health system a little bit more, that the primary care provider could have on an individual's information access awareness. And so what we've seen, which is probably a loose correlation here, the more that healthcare providers play a role in letting their patients know you can get access to your health information, the more people engage in accessing their health information. Go figure. And so what we found out of the people that have accessed their health information, you've got a little bit of smartphone use, which I think we'll start to see change over time. You have the mix of smartphone and computer, and then you have a large proportion that are still using the computer today. Partly that's because the portals that everybody has are somewhat clunky. They're not necessarily mobile friendly at this stage. Some of that we're going to be working on in terms of FHIR-related APIs, and I'll get to that in just a second. But it's important to understand where the population is and how they're accessing their information and where they feel comfortable and how they feel comfortable doing it. I just had this conversation with my mom. I use mobile banking for everything. Very little cash. Mom, hardcore cash person, writes checks. We just had this conversation. And so she is not on this pie chart because she doesn't even use a computer to access her health information. And that really segues into the next question. The only solution here is more apps. Just kidding. So what we did find, though, with the data is some interesting trends. And I would say, again, I want to see how things change as a result of the pandemic, because for those, for all of you, for us in the States, getting access to our lab results was really important the last 2 years, especially if you needed to travel or go to a conference like this and you had to get a PCR test or something in advance. You need to know how to get that quickly. And the only way you're going to get that information quickly is not on paper, right? You're going to get that digitally. You're clicking refresh, waiting for that test result to come in. And the interesting trends that we see here, though, is that people prefer to speak to their healthcare provider. That hasn't changed very much over the past 4 years. And then the other one, which I would say is a value proposition challenge, not having a need to access your health information online. And so that requires both education, conversation, communication, engagement in one's health to understand why you would want to access it at all. And I have a little bit of a saying, kind of being in the middle. There are parents with kids and kids with parents. And sometimes when you're dealing with both, as like I'm in that generational part right now, I'm caring for 2 young kids. I have a mom and other, parental units, as I call them, because I'm from a typical New York divorced family. They're starting to reach an age where I'm going to have to start helping them coordinate their health care and go to different specialist visits and the like. And so they may not have a need to access their health information online, but I sure do, right? As the caregiver, it's hard for me to manage my life and my kids' health care and then have to be a caregiver for somebody else unless I have tools available to me to do that. And so from a government activation perspective, that's one thing that we're trying to work with the industry and the market to encourage as much as possible. Okay, standards and exchange. So this is going to get a little bit of the technical side of our journey and where we're at. We have something now that we established a few years ago, which we call the United States Core Data for Interoperability. And this really serves as the data set that the industry can take for granted as the baseline set of data that would be available from a standards-based perspective for data exchange in electronic health records. I know it's a little bit of an eye chart. Wait until you see the next graphic. But the moral of the story here is that we're going through this annual process now with industry that we hope to raise that baseline through a regulatory process into the future as time goes on. But this is baked into our infrastructure now in terms of both from a patient access perspective as well as for healthcare providers to exchange from a summary care record perspective as well. This is version 3. Ta-da! It's really hard to see, and it was really meant for you to read all the details, but we have data classes as we describe them, and data elements that belong within each of those data classes. This is something that we've evolved over time, and certainly I think we can make the slides available, but you can also go to healthit.gov/USCDI, and you can get all the access to all of these in their non-minuscule font formats. Some of the data that we include here helps with patient matching. As many of you know, we don't have a unique identifier for individuals in the United States. That is a subject of political debate. So until that gets resolved, a lot of the individual record location, record matching aspects happen with lots of patient demographic data. And so, a lot of that is standardized now to the degree that that's used for both network exchange and other types of query. Much of the basic data that you would normally see here, the upshot is that this data gets represented in summary care records across the US for exchange. It's baked into our certification program. So health IT developers are required to be able to support this type of data as they go forward. Now this is version 3, which isn't currently regulated. Version 1 is, and that's currently what's getting put into products and upgraded and provided out to healthcare professionals by the end of this year. And so for version 1, I'll go back to version 1 for a second. That set of data is going to be made available via certified electronic health records and other health IT at the end of this year for healthcare providers, and made available via patient portals and other patient access APIs as well. Okay, so when it comes to APIs, for those of you that are familiar with FHIR, Fast Healthcare Interoperability Resources, we have regulated that. So we regulate the electronic health record functionality in this case, and say they need to be able to support FHIR Release 4, and that's the baseline standard that we've included. For the US, for domestic implementation purposes, there's something called the US Core Implementation Guide, and so that includes specific FHIR profiles for how you represent all that US CDI data into FHIR-based APIs. Now you may be looking at these maps and be like, I don't remember the US having this many states. For the statistical analyses here, we have something which is called hospital referral regions. And so these are different, gerrymandered lines of hospital referral regions in terms of how the kind of market segments in the United States are perceived by the statisticians and the like. And so when you look at the heat maps here, even the blue segment, that starts at kind of the 50% or less than 50%. On the hospital side, which is the graphic to the right there, you see it's quite red. And that is due to partially hospital market penetration and EHR developer market share. So you could probably take one guess in that mid-northern part of the United States, which electronic health record developer has a lot of penetration there, and how many hospitals are using that system. And so when we compare for those electronic health record developers that have gotten certified through our program with the healthcare providers that are attesting to having used them through the other payment programs, we're able to mash up this data and get a good sense of what some of the market penetration rates look like from a standards perspective. And so what we expect to see going forward into 2023 is a significant amount of FHIR infrastructure available for both clinical and patient access use case purposes. This is to give you another sense of what the US landscape looks like. As I mentioned earlier, we have lots of different health information networks. They offer different business models. They handle different types of exchange transactions. They have different types of technical architectures and various levels of maturity. Some have existed for 10, 15, 20 years. Some are relatively new in their particular jurisdictions as well. The graphic from the left comes from one of the trade associations that keeps track of and represents these different health information networks overall. But you can see even in a global economy like California, there's not one state network. So even from a governance perspective, the states individually, if they're large states, need to handle how many different health information networks that exist within their own jurisdictions, probably provincially similar in terms of the work that they need to do. And then you look across New York, the Mid-Atlantic here, lots of different health information networks. And so one of the charges that we received from our Congress as part of the 21st Century Cures Act was to create what's called a Trusted Exchange Framework and Common Agreement. The one agreement to rule them all is my joke for Lord of the Rings fans. But it's really to help level out the technology policy differences that exist across all of these networks and to allow for that original visions. So when I go to talk to my mom or other people that aren't in healthcare, the experience that we want to offer them is, you go skiing in, I wish I knew, was it Whistler? I was going to say Windsor. And I'm glad I stopped. So you go skiing and you fall, you get hurt, maybe you're unconscious, right? And the network is there to support healthcare, to discover so long as you have all your patient demographics, is there to discover your records and help facilitate your care. Could we do that today? Yes. Is it easy? Not so much. And it really depends on where you are and where you're getting that type of care. And so raising that overall network capacity across the United States is one of those things that we're working on, both from a policy perspective as well as from a local all the way up through the federal level. But you have to see here, as you note on the right side of the graphic, there are different networks that exist at a national level that we're starting to combine. There are other national type networks. Some of them are proprietary networks that are offered through different health IT developers. And then you have different types of exchange modalities that are still going to exist. So our public health infrastructure largely operates on HL7 version 2. Electronic lab result reporting, immunization reporting, syndromic surveillance, all of those are HL7 version 2 type transactions. And so they have a different type of network infrastructure that's going to be flowing across for all these connections. So keeping in mind all these different layers is something that we have to manage from a governance and technical implementation perspective overall. It's not always a light switch moment where everybody flips over to a particular different change. Okay, briefly about our Trust Exchange Framework and Common Agreement activities. We envision having these top nodes of the network. We call those qualified health information networks. The governance aspect underneath that umbrella is what's called the recognized coordinating entity. That's a public-private relationship that we have. It's an organization called the Sequoia Project, if you're familiar with them or have seen types of emails or communications from them. I won't read through the specific goals that we have for the Trust Exchange Framework and Common Agreement, but the exchange purposes, again, is really where we're leveling out the different policy variation that exists. And so making sure across all the networks today, they all largely focus on treatment, and then they start to splinter based on different market interests and geographic preferences for their stakeholders. So getting everyone to agree that these 6 exchange purposes will be acceptable for everybody participating across the Trust Exchange Framework and Common Agreement is going to be a really important change as we expect to see. So where are we going? As the segue from our TEFCA implementation, this year has been a real big governance establishment year. We released the Common Agreement at the beginning of January. We're accepting applications at this point in time for qualified health information networks, and we're looking to 2023 as our go-live period for active exchange to take place underneath the Common Agreement in 2023. As I mentioned, we have a heavy workload around standards investments and standards advancement. But again, the reason why we do the standards is not because the standards are cool, it's because they actually help drive health outcomes that we want to see and that you need to be powered by data to do. So all the nifty AI, machine learning type stuff that we're gonna be able to get from electronic health records or that are stored in data warehouses, we need that data formatted in certain cases. We need that data accessible, and that's really the highest priority, to make it accessible in standardized ways, to reduce the amount of friction it takes to get that data out and then make it usable for these other healthcare purposes. But also being aware of some of the uses or misuses of that data as well. And so you see, I'm sure across your market segments as well, looking at transparency elements associated with AI and machine learning and what it means and how it's coming to the conclusions that it may be. Lots of different agencies involved in understanding the implications of AI usage in healthcare. And so our office contributes to that as well. One of the things that's most exciting to me is automation and workflow redesign. Part of the reason why we see interoperability not succeed as well as it should, I won't say fail, or be limited in its impact, is because the workflow wasn't designed or redesigned to match the changes that were being enabled by interoperability. And so we've had instances where we've introduced secure messaging technology. Well, getting to that inbox and being able to use that data and then factor it back into an electronic health record workflow was not necessarily well designed in all cases across the industry. And so when we hear from providers, they're like, this is a lot of work for me. It isn't enjoyable. I have to go out of my normal process and go into this separate workflow inbox to go get the summary care record that you told me was magically available, and then it's really hard for me to integrate that data into my system. So those are some of the internal challenges that we have in terms of that shift from paper to electronic and then digitizing and making sure the workflows match the interoperability experience that policymakers and others were selling healthcare providers on those changes. Internally focused, we're working on helping our other federal agencies achieve their missions through digital health. And that occupies a lot of our time because we're a small agency. We're about 170 people. We have a $64 million budget. A lot of that goes toward people in terms of our staff. And so when you look at the impact that we can make, we look at our colleagues at the CDC who put out billions of dollars to public health authorities across the United States every year. And so we say, well, if we're going to make a big impact on public health interoperability, we have to work with the CDC. And we have to help them advance their mission through the use of digital health technologies, through the use of interoperability standards, because we know by doing so, it will make that data more accessible. It will make the public health activities more efficient, more effective over time. Last that I wanted to cover here, some convergence points. So we're starting to see, and I would say like this is the decade for different types of convergence, if I have to be a little futuristic. For a long period of time, the clinical data side has been separated from the administrative data side. And so all the claims and all sorts of other administrative type functions have been relatively separate from clinical provider and treatment. We're starting to see more and more crossover and usage there. One of the pain points that we have in the United States is prior authorization. And so again, another issue that can be enabled by some automation, by the use of digital data, in terms of having all that back and forth and all the time wasted in phone calls and unfortunately faxes still, that deal with the intersection between the clinical and administrative domains. Clinical and research, that's another area where, again, National Institutes of Health, part of our Department of Health and Human Services, they are looking at leveraging data now in electronic health records to do longitudinal studies. And guess what? The data's there now. We don't have to tell them that, well, you got to wait, we're still working on adoption, et cetera, et cetera. They can actually run, studies and trials and everything using electronic health records. And that at times requires changes and evaluation of our regulations. But that is something, again, from a clinical and research convergence perspective that I expect to occur more and more over time. And then lastly, if you caught in my overall executive branch agency's name, we're the Department of Health and Human Services. And so there's a whole section of our agency that deals with the human side of care, other types of services that are outside of an acute care experience, and integrating them and making them part of a person's whole care, a whole person care, and when they're outside of their clinical treatment has become really important in understanding. And sometimes it's referred to as social determinants of health, sometimes social drivers, but lots of programs throughout the U.S. in terms of the convergence potential there. And then lastly, health equity, which has been a component of our office in this administration more recently in terms of advancing as well. Okay, saving some time for questions, hopefully. Parting words, maybe of wisdom. As a child of teachers, my parents, I like to try to leave something for you to think about. And this is the biggest challenge of putting together a presentation. Going paperless doesn't mean that you've made progress. And that gets back to that workflow thing. Oftentimes we found the greatest frustration is that you take a paper process and you put it into the digital process. And for all of us, we're like, why? Part of that is time, part of that is other, pressures. But my encouragement would be, if you have the opportunity and you're shifting from one kind of medium to another, use that to do some redesign thinking, to really ask yourselves, is this the way that we would do this, knowing that we have this data accessible, these types of connectivity or connections available to us? Is there something that we can change to make that workflow different? Because there's nothing sacred about that paper workflow that makes it the best thing to implement in a digital way. So just keeping in mind that paperless doesn't equal progress all the time. Lastly, what we found in a mathematical equation here, when we work jointly with the private sector, we make a lot more progress than working versus the private sector as well. So I would encourage, as you have opportunities to collaborate with your government partners, with InfoWay, to do that as well. And then lastly, from a policymaker, what I found as well, coming through and using the momentum generating events and momentum generating initiatives is something that you want to try to do as much as possible from a game changer that you can use. So the Trusted Exchange Framework and Common Agreement for us has been one of those game changer type policy initiatives that we've been leveraging and riding for the past 5 or 6 years, and is really shaping industry perspective. And so when you can find those, you can really make substantial progress and bring other things along with it as you continue your work. So I will end my monologue here. Thank you very much for your time and the invite. Yeah. If you want to get a hold of me, my email's there. Healthit.gov is our website. Tons of resources available. We have a whole data brief section for some of the statistics that I mentioned as well.
Any questions for Steve? We've got a few minutes. I think there's somebody. Oh, yeah, go ahead. Thank you.
Can you talk a bit about the financial incentives that have actually driven the digitization in the States? Like, CMS funding tied to meaningful youth adoption?
Yep, absolutely. Yeah, so the question was how financial incentives being tied to certified EHR adoption has played out and been orchestrated, I guess I would say. So in the 2011 time period, that's per the chart that I showed you earlier, Congress passed the law, which roughly equated now in today's dollars to about $40 billion worth of incentives that were available to the industry. They staged the timing for the incentives that were available. So you had to do some work and adopt the electronic health records in order to get incentives on an annual basis for that early period of time. But the way that it's connected, which is really the most important thing to kind of convey and answer your question succinctly, my office doesn't have any mandatory or compulsory ability to say, you, industry, you must follow these standards. It's always connected to a financial program or other policy lever that incents the different stakeholders that are involved. And so the electronic health record developers could generally ignore us if not for their customers' need to participate in these government programs and the requirements that in order to do so they use certified technology that bakes in the standards and the like. And so the financial incentives played out as a carrot early on, followed by, on the hospital side now, there are some penalties. We would call them downward payment adjustments. They get negative reductions in their payments if they don't use the technology or meet certain program requirements. On the ambulatory side, it's a little bit more complicated. There are different weighted programs that all get added together. But nonetheless, it has a similar kind of payment reduction if they don't stick with the program and participate. And that exists today. I could go on, but that was...
Steve, there's a question from a webcast attendee. Awesome. Is there a national tooling strategy for ONC? If so, can you please elaborate and perhaps list some of the main tools leveraged to manage ONC activities?
Yeah, so we do get involved in, if tooling means for like testing. So for our certification program, obviously that is software testing. We actually partner with third-party private sector organizations to do that on our behalf. It's a little bit of delegated regulatory authority there. We maintain certain testing tools for that program operation overall. So we have testing tools for HL7 version 2, for our consolidated CDA summary care record tools, and we have a, as everything fire, pun named, it's called Inferno. It's a fire testing suite. That code is publicly available though, so if you're interested in testing fire servers, we have a very rigorous fire testing client effectively on steroids that helps test fire servers. Certainly it's optimized right now for US domestic type testing, but we have a component of it that is focused on what we call community type testing. And so for anyone implementing the fire specification in our part as a government agency to help advance the standard, that's one thing that we've been supporting as well. So that's a little bit on the testing and tooling aspect of things. Hopefully that answers that person's question. We didn't plant this question.
Tell me about the patient adoption of healthcare records. Does it work? Does it deliver benefits? How's that going?
All right, the question was around patient adoption of health records and how it's going. So this gets to an interesting mix of best intended policy and then how it plays out into market reality. So as part of Meaningful Use Stage 2, which is around 2014, we introduced a requirement for what we called view, download, and transmit to a third party, VDT. And the notion there was, if you're going to be a provider participating in those programs and you want to continue to get government incentive money, then you need to use certified technology and make a patient portal available that would allow us to view and download our information. And that was, the behavior change that was being incented. So guess what? Everybody has portals. And not only do you have one portal, you've got a portal for every provider that you go to. And so, it is a challenge of our own making. So in one respect, we are awash in access. Now, my personal point on this is the access right, as was discussed even for here. It's important for everyone in the population to know that they have the right to access their data. Whether or not they need that data at that exact moment, or if they're accessing it, so that 60% statistic that I showed earlier, it doesn't bother me too much, because if you don't need your data at that particular time, that's okay. I don't expect everyone to access their data all the time and, like Facebook. But what you want to know is that you have the convenience to get it as soon as you need it. And so if you're going to go on a trip and you want to look up your immunization information, you want to just be able to do that. You don't want to have to go through the hard, rigid process to be able to access your health information. And so right now, I think we're in the technology is there, the culture hasn't necessarily caught up to the fact that the technology is accessible. Now that being said, Apple has done a great job. If you're an iPhone user, you can use the Health Records app. You can look up all these places that you've gotten care, and you can download it to your iPhone. And guess what? They're using the FHIR standards that we help to regulate. And so, you have a good example there where the private sector saw a market opportunity to make an investment, bake it into their operating system, right, which is quite unique from an Apple perspective, and then enable, all of the customers to kind of use that. And I didn't mean to make that like an Apple commercial here. There's great Android work going on as well. But the other dynamic on the patient portal side is, the market incentives for each of those portals exist for other reasons. So if you're a healthcare provider and you want them to schedule appointments, especially under fee-for-service, you want them to come back to you, right? And so if you make it easy for people to schedule their appointments, then that's what's going to keep them coming back. Or other types of value-added services. You have to use our portal to do secure messaging with your doctor type of thing. And so abstracting out some of those capabilities and functionality, I think we'll start to see shift in the next 5 to 10 years as well, where the commoditized features start to shake out.
Thank you so much, Steve. I think
we went over.
But we only went over because of questions.
That's
so
right.
you didn't go. That doesn't count. But that was a really frank, and we really appreciate your sort of honesty and the good, comma, the bad, comma,
yes.
and the ugly. So I learned two things. You have as many acronyms as we have, which
Totally.
is good. And Flavia, our patient partner, reminded us yesterday that interoperability is sexy.
Yes.
And you talked about collaboration and coordination as a superpower.
Yeah.
So I'm feeling pretty good about things right about now. Just a reminder, 10 o'clock, our concurrent sessions start. Okay, let's apply for a second.
No, thanks. I didn't want to.